I've been on a lot of AI things and going through different podcasts. In any case, I just recently asked Pilot, what do you think about scoring or using ORP for in seeing a little bit more in a sleep? And this is the answer, and I wanted to share it with you. This is what Pilot from Microsoft artificial intelligence program said. ORP, which we can find in the EEG data from sleep study, is like a signpost that shows certain patterns in your brain waves. These patterns can tell us if you have different types of sleep apnea or other problems. And the GI actually said, think of it like this. Imagine you're looking at a map of a city, trying to find all the coffee shops. The map is your EEG, and the coffee shops are the sleep disorders. The marker, ORP, is like a special symbol on the map that points out where all the coffee shops are. So this is what I want to share with you today. I hope you are safe, you're not driving anymore, and I can share some images with you. Thank you for the trust in sharing your patients. This is a young woman, 22, who has had sleep paralysis for at least 3-4 years. She had frequent episodes at some point, and those episodes decreased with an increase in the dosage of an antidepressant and SSRI. She describes, or your chart describes, a recent episode. The patient felt like while being asleep, she was shaking, convulsing, her heart was racing, and felt like she might die. She was unable to say help. Since then, she has struggled to go to sleep, of course, and stay asleep. It just feels like her brain wakes up before her body, and she used to have lucid dreams when she was younger, which is interesting. No symptoms of cataplexy, restless legs. She goes to bed late, around midnight, wakes up around 8 or 9, and maybe wakes up once in the middle of the night, apparently because of anxiety. She feels rested, everything is normal. She is depressed and anxious, according to these scales, clearly, and she is taking these medications, particularly sertraline, at very high doses for depression and anxiety. She drinks 2 cups of coffee, nothing more significant in this history, other than she is a dancer. Apparently, this imposes some anxiety on her, rehearses late shows, apparently, something like that. I gathered from the chart. So this is the sleep study. And as you can see, with the conventional architecture, you can see good sleep efficiency, a little bit of delay time in the sleep onset. Sleep was quite fragmented, a lot of awakenings, arousals, wake after wake, so increased, and almost no N3, and still a significant decrease, but still significant amount of REM sleep considering the large dose of antidepressants. What we do with ORP is going through the different sleep stages, and I have here a little box where you can see what we have as a reference value. So N1, which is supposed to be transitional, is indeed that. N2 for her is average sleep, light sleep. N3 is very good, very nice, deep sleep. Overall, her REM sleep is transitional, as well as the non-REM sleep, which is light sleep. you can see that her awake is, and I will show you interestingly, is not fully awake. She is drowsy awake. And I'd like to show you, well, this is a slide just to show that she does not have anything clear in the conventional EEG that can show why the sleep is so disrupted. And the most important thing is why is she having all these symptoms. So what I put here is the regular histogram. And in this particular case, what I decided is to put a little mark here. Anything below 1, most technicians will recognize as being asleep. And I marked here the REM. She had 4 REM episodes, which again is a little unusual for somebody having such a high dose of sertraline. But the interesting thing is that anything, and I showed here, close or above 1.75 rather, is being almost always awake. And you can see here that in REM, she wakes up. See, in REM sleep, she is waking up. So whatever she's telling you is right. She is waking up in the middle of REM. Her REM sleep, overall, the entire sleep is very superficial, other than the deep sleep here, very nice. Her entire sleep is very superficial. And this, our technician is called as N2. However, she has a very deep sleep. This is interesting because we have this impression that depression typically shifts the ultradian rhythm and moves the N3 occurrence to the second part of the night. So this is consistent with or suggestive of her depression diagnosis. So then we have another way of interpreting or showing the ORP. This is the normal. This is the graph I just showed you. This is the normal pattern, now in a different way of explaining. This is what we have for this particular patient. You can see that she has deep sleep, but the most important is that she has most of the time her sleep in this is here in the middle, where light sleep and transitional state is present, sorry about that. And this is consistent with a very superficial sleep. However, she is not fully awake when she's supposed to be. I think that because she's very young and she's all day and a student and a dancer, she doesn't feel sleepy, she doesn't have the time to nap. But this is consistent with this parasomnia that is causing anxiety and triggering probably more depression and anxiety symptoms. Do you want to stop with every single case for questions, or you want to wait until the end, Dr. Roy?
Yeah, why don't we wait till the end?
Okay, good, great, thank you. So now we have another young woman, 20 years old. She complains basically of having excessive daytime sleepiness, even while driving. She's always tired. She has a hard time getting out of bed. She has a struggle with this sleepiness ever since she was 10 years old, often dozing off in high school classes. She has had occasional sleep-related hallucinations and paralysis. Occasional snoring is suggestive of moderate sleepiness. At some point, she was offered trazodone, and she didn't like it because of side effects. At some point, she was also on medications to keep her alert, but she claims it was not necessarily very helpful because the effort remained the same. Now she has regular sleep schedule. She wakes up in the middle of the night a couple of times because of the pet or a little bit of anxiety. And she may occasionally take very long naps during the daytime, apparently not every day. Normal vitals. She has anxiety, depression, attention deficit disorder, as we can see in the markers here. No medication at this point and no consumption of anything like this. And this is the conventional sleep architecture, where you can see that sleep efficiency was good. Took a little bit of time to fall asleep. Some awakenings and arousals, not significantly fragmented sleep, and relatively good sleep architecture, a little bit of decreased proportion in N3 and REM. What we see with ORP, again, if we compare to this little square here, you can see N1 is not as the transitional state that we thought she could have, or any normal person without a sleep disorder. She is a little on the light sleep. N2 is really deep. N3 is very, very deep. REM sleep, as you can see here, is on the average sleep, which is good. Non-REM is very deep. Overall, all stages suggest that she has an average sleep, but when you see the difference between the stages, it seems like she is on the very deep sleep. But importantly, when she is awake, again, she is not fully awake. She is in this drowsy wake. And this is consistent with her concern, with her complaint. I am sleepy all the time. So this is a marker to make sure, or to actually assure the patient, rather, that we believe what the patient is saying. This is a graph, nothing physiological disrupting her sleep, nothing significant. And because I'm missing one graph here, and this is her pattern. This is the graph. Here, didn't show you this, I'm sorry. This is the same table I showed you before with the histogram, and when we add ORP at the same time, you can see again, everything below number 1 is going to be scored by most technicians as being asleep. She has very deep sleep, nice sleep. As you can see, most of the time, she tends to go to a very deep sleep, as she described being very difficult to be awakened. Another interesting thing is she's awake here, like people are when they arrive to the sleep lab. They are aware of things and the little red light in the finger, but then she falls asleep immediately, and right away she goes into deep sleep. A little bit of awakenings, but nothing really significant. And the graph here with the bars, you can see that all the time, most of her sleep is deep sleep. So with this graph, you can say that she has hypersomnolence, and we can confirm that diagnosis. This is another woman, another young woman. Thank you for sending all these women with sleep disorders. All of them, the 4 of them are women. This woman is 37 years old. She complains. She has another interesting story. She was diagnosed with a large tumor in her sinuses in June 2023. She, around all this process of the surgery and the diagnosis, the finding of this tumor, she had headaches. She was very anxious, of course. The tumor was benign, successfully removed, but she had extreme anxiety leading up to the surgery. She has tried many things. Interestingly, she's a pharmacy technician. And she has tried many things, melatonin, over the counter, but also Zolpidem, Lunesta, Trastom, with minimal benefits. Recently, hydroxyzine has helped, but she feels sleepy during the day. No snoring, relatively stable sleep habits. On weekends, she tends to delay both the bedtime and rise time. And most of the time, it takes her about an hour to fall asleep. And then she wakes up numerous times during the night with difficulties falling back asleep. Sometimes she claims she sleeps 2 to 3 hours, even when staying in bed trying to sleep 8 hours. She has normal vitals, a little bit of, well, not a little bit, a lot of depression and anxiety by the markers. And she does not drink alcohol, caffeine, nicotine. I have a problem here. We find where she is. Sorry about this. Here. So this is the conventional sleep, total recovering time, total sleep time. Of course, she has insomnia. The sleep efficiency is decreased. Took her 18 minutes, not so bad for somebody that claims that takes her about 1 hour or more to fall asleep. Not significantly fragmented sleep. She did not enter N3. With ORP, we have transitional sleep in N1. N2 is not bad. Average sleep, not very deep. REM sleep is transitional, not a REM, not a very deep quality of sleep in REM sleep. Non-REM is not bad, which is good. Her wake is relatively good to the high level. Still not fully awake, but that night it wasn't that bad. She had a few apneas here and there, nothing significant, no leg movements, nothing that could explain the sleep fragmentation or the poor quality of the sleep. In the graph that I've been showing you, you can see again, number one here, the line here, everything below is going to be scored as sleep for most technicians. Here you can see that her sleep, most of her sleep is above that line. Most of her sleep, even when you see a relatively good histogram, she has some time awake. She has more difficulties staying asleep. But even when she is asleep here, she is here in this transitional state or drowsy wake. And her pattern is more to the awake side of the graph with a little bit of deep sleep, but not significantly. We want patients to have a deeper sleep. So this, according to the history and the shape of the graph here and here, with at the same time that the sleep histogram is suggestive of insomnia. And finally, we have another young woman, 34 years old. She complains of having snoring and witness apneas. She has difficulties of falling and staying asleep and has daytime sleepiness, although the report is not suggesting very mild sleepiness. She has good sleep habits, wakes up a couple of times. She has a history of migraines and anxiety, not significant values for anxiety in this score. And she also takes hydroxyzine to sleep occasionally. She could be one of my favorite people because she's a zookeeper. I would love to be a zookeeper. If I wasn't a physician, I could be a zookeeper. Anyways, sleep. Total recording time is good. Sleep efficiency is good. Took her half an hour to fall asleep. Significant amount of time awake with sleep fragmentation, no N3. And when we see the ORP, again, N1 goes to the transitional state, N2 is a little light to sleep, no N3. REM is light to sleep, non-REM is light to sleep, wake is not bad, going to the full wakefulness, and she has obstructive sleep apnea, moderate obstructive sleep apnea, with no significant impact in the oxygen, a little bit of legs, not causing arousals. And this is her graph. And as you can see, we have apneas here. Oxygen is good. No N3. She has 4 episodes of REM. Again, this line around 1, which is going to be considered sleep by most technicians, can show you that she has this significant time awake and in the transitional, and this coincides with the sleep fragmentation we see here and with the apneas. So this patient has something that is preventing her from getting into deep sleep. And that is the apneas, that is the sleep fragmentation associated with sleep apnea. So she has this endotype of sleep apnea that is not necessarily having a significant impact in oxygen, but is fragmenting her sleep, and you can see it here. So this will be, now we have this other graph consistent with having a lot of time in the transitional range, not significant deep sleep because she's being awakened most likely by the respiratory events. So what do we have? We are trying to identify some sleep apnea, obstructive sleep apnea endotypes to see if by using ORP we can predict if there's improvement with the use of CPAP. And there was a study conducted by Dr. Yunus' team, and what they have seen is that these people, and it's of course this is some patterns that he described, and not every patient are exactly as these patterns, but say your patient is having little sleep, like the pattern we call 1-2, with little deep sleep, relatively good wake time, but a lot of time in the transitional range. We believe that these kind of patients will significantly improve as opposed to others when we use CPAP. And we will likely see increase in the deep sleep with decrease in this sleep fragmentation. So finally, these are all your patients. And we can say that very likely this patient has fragmented sleep. Why her REM sleep is so fragmented, very difficult to say. Of course, ORP is not that fantastic to tell you why. It's a marker. to say that she's right. She's waking up in the middle of the REM sleep. This is probably a benign condition, REM parasomnia, but anxiety and depression might be playing a role in her sleep fragmentation. And this will be similar to this case where sleep apnea is fragmenting her sleep. This is insomnia with a lot of time in the range of being awake and transitionally asleep. And this is a case of idiopathic hypersomnia in the absence of clinical data of narcolepsy. And this is all I have for you. And I will end by saying that we want ORP to be employed as a distinct marker within the EEG that you already have during standard PhD. And we want physicians to use this marker to assist in identifying these different genotypes and have a more personalized medicine to help our patients with the sleep disorders. Moreover, it will be interesting for us as sleep physicians to understand and learn what is really happening and give us more information than what we obtain in the regular EEG. And I will say, let's grab a coffee. And this is what I have for you.
Thank you.
Do you have questions, Dr. Roy?
Yes.
Or the rest?
So,
yes.
Yeah. So if we go back a slide to, yes. So the question I have is around the top right one. In a patient.
Top right.
Yeah, the one that's the deep sleep.
Yeah, that's mm-hmm.
Now, when we look at narcolepsy versus idiopathic hypersomnia, there is often a distinguishing feature that narcolepsy patients are actually very fragmented and very little deep sleep.
Yeah.
So if we see a pattern like this, but the rest of the history and the MSLT is consistent with narcolepsy, what are some of the clinical implications, I guess, of that? What are we seeing here that argues that this isn't narcolepsy?
Yeah, I agree with you. Definitely, this is mostly based in our therapeutic decision is going to be based in the clinical symptoms, and of course the MSLT, because that is what the guidelines are saying. Still, the MSLT is a study that was designed and described many years ago with no significant changes in the parameters. And I agree totally with you that usually in narcolepsy, in pure narcolepsy, we see patients even with a little bit of a sleep apnea because they tend to be little obese because the orexin problem. But yes, there is sleep fragmentation. And in this particular patient, we didn't see that. I can't tell you that ORP can go and substitute for what we have in the guidelines. But if this patient had, say, the criteria in the MSLT for narcolepsy, your call in establishing the decision, I will say that these particular patients, for some reason, had a very high pressure to sleep. It's difficult to understand why, and probably because MSLT is not necessarily accurate, in my personal opinion, because it's a very old tool that at some point will need to be addressed, and it's based on regular standard EEG. I would say that's why we have some other biological markers. like the genes, to really confirm the diagnosis of narcolepsy or the family history. Hope that answers your question.
Yeah, no, that's helpful. And then the patient with sleep apnea who's
Yes.
fragmented, the challenge I think will come into our ability to reassess this on treatment.
Yeah, we don't have the time. Waiting lists are really bad. So that is precisely why the idea of getting these studies is to assess if your patient is likely to improve. Because if you have somebody with a sleep apnea and already deep sleep, the likelihood of improving with CPAP is probably not much. They probably won't improve much. If, on the other hand, you have a patient with sleep apnea and a lot of time, like in this graph, awake, or here, this is a patient likely to have sleep apnea and insomnia, these fashionable CAMISA patients. And it's going to be difficult. It's going to be a challenge. The patient will probably improve with CPAP, but probably won't like it because it's not improving much due to the insomnia. So we want to have a marker, the ORP, to tell you, you know what, this seems like her sleep fragment you that respiratory events. And if you put her on CPAP, she will improve. Will you have another sleep study to check this? Likely not. But at least you know, and you will have your resources, your clinical resources, your time to understand or to know what patient is most likely to benefit and to design a treatment, in my opinion, that is personalized, as I said. If I see this pattern, she will likely improve with CPAP. I send the prescription for CPAP to the provider, and she will likely be happy. If I have a different patient with insomnia, then I will probably need to take a closer look. Probably a follow-up because of insomnia, probably adjustment in medications. So I don't think we are now at a stage where a regular EEG and diagnosis of sleep apnea with AHI is equal to CPAP. At this point, we have to personalize treatment and diagnosis. And that's the idea of the ORP.